Hi, Elizabeth.
Hey, Sharon, how are you?
I'm great. I'm great.
Good.
I have a question for you.
All right.
People ask me about this, and I think you're the best one to explain this.
Uh-huh.
What is trauma-informed care?
It's a frame of reference and a way of thinking about the people that you're working with. So, trauma-informed care really is a frame of reference and a way of relating more than anything. It's based on what people think about other people and about the experiences that folks have, and it relies on a common set of characteristics that we'll talk about in this and other videos. And it usually refers to behavioral or mental health care, but it really is applicable as a way of responding to others in any setting. I think I've heard you talk a couple of times, Sharon, about some of the patients you've worked with as an occupational therapist, where you see folks go in and they just flap the covers back on a patient, and then when the patient gets agitated because their lower abdomen and their genitals are exposed, the person acts as if it's no big deal.
Right.
Tell me how learning to think about from a trauma-informed perspective has helped you with that and helped you respond.
Well, I even had an incident where I had to even remind the daughters of this patient after attending your class. When we were trying to help this lady get out of bed, just to start to pull the covers back, she instantly grabbed to cover everything. And the daughters, being comfortable with their mom, started to just rip them back. And I said, let's just wait a minute. Let's let her pull the covers back. Let's let her be in charge of when she's exposed and how she's exposed.
Excellent, excellent, excellent. And that's so critical. We forget that, especially when people are receiving physical health care, everything that's happened to them in their life comes with them. And you put people in a facility where they are residential, congregate care, rehab, skilled nursing, any facility, and they're automatically back to being unable to control who comes and goes in and out of their room. People can ask them to do things or make them do things they may not want to do. They may not have adequate protection. They may be medicated so that they can't really focus on their own choices, and if they resist or complain or it takes them a while to get things together, then they're considered resistant, right?
Absolutely.
Right. Clearly you found a way in that case to be respectful, to foster connection with that patient, to give her hope that she was going to be treated really like an adult and a human being who had needs, without shaming the children. And that is so critical, because the children may have no idea of whatever it was that may have caused the mother, in addition to modesty, be uncomfortable having her being exposed physically. Good stuff. Very good stuff.
It's been helpful.
Have you seen it working with your pets?
Well,
Yeah, it really does work with pets, and I'll talk about that in another clip. Let's stick to people right now. We've just heard an example from physical medicine and occupational therapy. That's a clear example of trauma-informed care, which places the person receiving services in the center of the relationship, what we call customer-centric in business. And in disability activism, this is called person first. Now, both of these do something that can make any of us fairly uncomfortable, and that is they afford people that we call different, people with diagnoses of medical problems or mental health issues, or people who have who relate in different ways that we're uncomfortable with. It gives them a higher degree of power, respect, and authority than we're usually comfortable with, because it means that we have to change how we think and how we relate to them. Let's take a look at a different example.
A classic story, a case that we use in the training, a woman who's homeless, who's been homeless for going on 20 years, who comes in, we're not sure where she comes in, but she's unkempt, she's disheveled, she is mumbling to herself, she is incoherent. She has been diagnosed in a system that's very traditionally oriented as a schizophrenic.
There are two key questions that this brings up in trauma-informed care. How might these behaviors be helpful to this person, and how might these behaviors be related to something that happened to her instead of something that's wrong with her? And we're looking for other answers besides they get her attention, they tell us she needs to be on her meds, she's trying to manipulate us, or she's just a schizophrenic and this is how they act. Because these other answers help focus on how these behaviors are really meaning-making. Let's listen further.
This woman actually left home at the age of 15 to get away from an abusive family. And, when you begin to look at the strengths that she has, this is a strong woman with a lot of gifts. We look at the institutionalizations, the incarcerations for petty theft, prostitution, vagrancy, and we begin to, and there are two ways to look at it. One is it helped her have shelter, food, and clothing in the wintertime, and the other is she's mentally ill and she's dangerous.
Okay, consider the facts. She made a life-supporting decision to leave home at 15, has enough street smarts to live out for 20 years, may have minimal access to facilities to bathe, or may find a measure of safety in being unkempt, has had little company or consistent contact to help her stay grounded, fill in developmental gaps, and mature, supports her own safety by acting dangerous, and uses alternative methods to support financial needs and needs for food, shelter, and clothing. So trauma-informed care puts a whole new spin on this. It factors in the known impact of traumatic experiences. It looks at the adaptive function of behavior. It considers the person in relationship to their history, and it may challenge diagnoses from other frames as well as meaning and attribution. It looks first at how to engage the person from the health they have instead of a disease-based perspective.
And which of those is more helpful to her? We need to learn new ways of being. Medication can help us feel better while we do that, but if we simply take medication to feel better and we're not practicing different behaviors.
So instead of learning coping techniques, we kind of just keep masking the...
Instead of learning coping techniques, we just keep kind of masking the issue.
Curious? Join the conversation at www.traumainformedcare.com.